But we can't talk about the future without situating it in the present and the past. And so I want to uh, dwell a little bit on the present when it comes to mental health and a little bit on the past, because then we understand why some of these, thought processes on the future are important to talk about. And if we look at what we know today about mental health, be it the high burden, be it why mental health problems occur, be it the innovations around increasing access to mental care, be it this understanding about how social determinants have an influence on mental health, knowing all of these things, if we kind of indulged in a cognitive experiment to think through, would we design mental health systems the same way now that we have all of this new knowledge? Would we design mental health systems the same way as we designed them before? Then the answer to that question probably would be no, that we would do it differently. But despite that, what we find is that health systems today are designed in the same way that they were done 15, 20 years before. We still have health systems which are designed around psychiatrists and psychologists, and maybe psychiatric social workers. We still have health systems which are mental health systems which are quite fragmented and separate from the rest of the health and social care systems. We still have mental health systems which are very biomedical, and we still have mental health systems which do not pay any attention to the individual who has mental health problems or the people with lived experience. And a lot of it is to do with what we are not paying attention to. Because we know a lot more about mental health than we did 15, 20 years ago. We know a lot more about how mental health problems occur. We know a lot more about what we can do about these mental health problems. We know a lot more about how we could design systems which are more ready to respond to these mental health problems. But despite that, a large proportion of people with mental health problems today do not have access to mental health care. Despite knowing a lot of these things, access to mental health care remains inequitable. It depends on who you are, where you come from, how much privilege you have, or otherwise. And the questions for us today, because the topic that I'm supposed to handle is innovation, is not about whether we can innovate, or where we'll innovate, or how we'll innovate. The question for us is, who will benefit from this innovation? And the reason we have to ask this question is that globally, despite all of the knowledge that we have accumulated over the years, mental health problems such as depression account for a substantial proportion of the burden that results from all health problems, not just mental health problems. Despite all of the knowledge that we have, a substantial proportion of people who have mental health problems do not have access to any kind of mental health care. Despite all of the knowledge that we have, every year we have 8 million people dying of suicide across the world. And if you think that this is a problem that's affecting only low and middle income countries such as India, then it's a wrong notion to hold. The same problems, albeit slightly differently, affect high-income countries where you would assume that the resources are much better. But even in high-income countries, we see that while care is available, it's uneven. While care is available, the quality of the care varies quite a lot. And even when you have many resources, there is a huge difference in who has access and who does not have access to care. And there is marginalized communities who still do poorly when it comes to access to mental health care. So this is not just a problem of low resource settings and low and middle income countries. This is a problem that affects the whole world, regardless of what resources we have and don't have. And the reason why we are in this situation is because historically, we have defined our solution to this problem through a metric called as treatment gap, which is basically, if there are 100 people with mental health problems, what proportion or how many of those 100 people have access to mental health care? So that's been the single most important metric on which the whole argument or advocacy for access to mental health care has happened across the world. And there are problems with this metric because it does not take into account a lot of other important things which we need to be thinking about. And these are things such as the detection gap, because treatment gap only takes into account people who have been identified or diagnosed to have a mental health problem. But the fundamental problem is that a substantial proportion of people with mental health problems never ever get detected. So the question of them getting treatment doesn't even arise. The question is about access gap. You might detect people with mental health problems, but if services that you put in place are geographically or financially inaccessible to the people with mental health problems, then the question of receiving any services does not arise at all. If you have to travel long distances to get to a clinic or a hospital to receive care, or if you have to travel to a clinic where you have to pay large amounts of money which you can't afford, then there is an access gap because geographically or financially you can't access the health service. Then there's a quality gap. You might be detected to have a mental health problem, you are able to get to the clinic, but what you receive there does not meet global evidence-based standards. If it doesn't meet that, probably it will not help you in any way. There's a continuity gap, which is basically health services or health systems today are designed to respond to a person once they have developed a mental health problem. There is nothing happening to prevent that person from developing that mental health problem in the first place. There is nothing happening to provide rehabilitation and recovery and reintegration into society for a person with mental health problems once they have recovered from the mental health problems. So it's an episodic treatment which only covers you when you have acute mental health problem, but does not look at the two other sides and the key sides of the problem, which is prevention and rehabilitation. And then there is the equity gap. Who you are, what resources you have, how much privilege you have, whether you live in an urban setting or a rural setting, whether you are employed or otherwise, whether you are a male or a female or any other gender, all of these things determine whether you have access to mental health care or not. So it's not an equitable access where everyone, regardless of any of these factors, will get access to care. So the question is not about what we are able to deliver. It's not about innovation per se, but it's about the system architecture within which we situate all of these innovations. And let's speak about some of these innovations which we want to look at in the future. And when I say innovations, and when I speak to a lot of young people that I see in the audience, the first response, or not just young people actually, that's unfair, it's not right, most people that you speak to, and when you speak about innovation, the first thing that people say will be technology, right? Because people think that technology is the only innovation which is going to solve all our problems. But the reality of the matter is, within global mental health and within the larger global health field over the years, the most significant innovation has had nothing to do with technology. The most significant innovations have been around what we call as delivery redesigns. You redesign how healthcare delivery happens, and which has nothing to do with technology. And let me give you an example of one such delivery redesign, which we call as task sharing, which is a rational redistribution of frontline healthcare tasks to people who are not specialists, who are not psychiatrists, who are not psychologists, who are not psychiatric social workers. Task sharing across the world within the mental health space has challenged one of the biggest notions around mental health care delivery, that you need specialists to deliver mental health care. And there is substantial evidence now from many parts of the world, a lot of them low and middle income countries in Asia, Africa, and South America, which shows that you can effectively deliver mental health care across the lifespan, which is children with developmental disabilities, young people with mental health problems, adults with mental health problems, including addictions, and elderly with mental health problems. That's across the lifespan. Different kinds of mental health conditions, right from developmental disabilities in children to common mental disorders, depression, anxiety, to different kinds of addictions, to dementia and caregivers of people with dementia. So different kinds of conditions, different kinds of activities, which is identification of people with mental health problems, providing psychological interventions, monitoring people who are receiving medications, providing rehabilitation services, and a whole spectrum of non-specialists. At one end, you have medical professionals who are not specialists, not psychiatrists, nurses, general practitioners. At the other end of the spectrum, peer delivery agents, people who have lived experience of mental health problems. And in the middle, a whole spectrum of different kinds of health and non-health workers, such as community health workers, family members of people with mental health problems, what we call as lay counselors, people from the community who has been trained to deliver psychological interventions and other mental health care delivery. So this has challenged the notion of who can deliver mental health services. And you have evidence from different parts of the world to support this. And this as an innovation has changed the global mental health field and increased access to healthcare. But that's not to say that technology doesn't have a role to play as an innovation, right? We have to address the elephant in the room. While I'm not a Luddite, I still am a healthy technology skeptic when it comes to healthcare delivery, especially mental health care delivery. And I do not see technology as the answer to all of our problems within the mental health space. I do see it as a force multiplier. There are things that technology can do for us. Some of the things that I've listed there. It can help us in identification. It can help us in training and supervision. It can help us in being more precise in the interventions that we can deliver, because we'll have a lot of data coming from a lot of people, which allows us to map our interventions onto a particular individual based on all of that data. But it's not the answer to everything. So we can allow technology to enable us, but not replace us as human beings who deliver psychological interventions or other kind of mental health interventions. So there's a role for technology, but only as a force multiplier, at least the way technology is designed at the moment. Let's shift away from innovation at the moment and think a little bit about inclusion, because that was the second piece of domain that I was supposed to cover. And when we think about inclusion, we think about inclusion as a moral add-on. It's something that would be good to have. But that's not enough. Inclusion should be, for all of us, a must-have and not a good-to-have. And I would want to kind of pose 3 different questions for you to think about, because they intersect a lot with mental health care delivery and how we look at mental health care delivery in the future. So the first one is, are we over-medicalizing distress? And let me tell you a story from a piece of work that we did in rural Maharashtra in Vidarbha, which many of you will know is plagued by farmer suicides. So we're running a program there many years ago where we trained primary healthcare physicians, we trained community health workers, we trained people, volunteers from the communities, basically to identify people with depression, provide them, and drinking problems, provide them with medication if required through the primary care services, provide them with counseling using non-specialist community health workers. The idea being that if we could reduce depression and if we could reduce drinking problems within those communities, then we could reduce farmer suicides. And what we found was that access to mental health care within those settings increased exponentially in the years that we were running the program. And at one point down the line, we had a big dissemination event for the program in Nagpur, where we invited policymakers, various different stakeholders, to talk about the program, to share information about the program. And one of the things that we did was to invite some of the beneficiaries of the program to come on stage and speak about the program and their experiences of receiving interventions through the program. So we had this middle-aged farmer who came up on stage and spoke about his experience of the program and kind of spoke about the symptoms of depression that he had. He didn't know that it was called depression. He met the community health worker. They identified the depression. They started him in counseling, and he got better. So he gave a glowing testimonial of the program and said, I had depression before, got treated, received a psychological intervention, and then I didn't have depression. But it didn't stop there. He then went on to say, I do not have those things that I was experiencing before. I don't feel sad anymore. I'm able to sleep well at night. My appetite is improved. But what has not changed is that I'm still poor. I still don't know where my next meal is going to come from. I still don't know where the money is going to come from to pay the fees for my children when they go to school. And so, if you look at it purely from the diagnostic perspective, you say, okay, we did our job. Depression is not there. But what about the distress which is situated outside of the mental health domain? Are we over-medicalizing distress, which is a part of life, and where the response should be different from just giving people antidepressants or psychological interventions? And the response should be much more structural. Instead of doing that, are we converting it into a medical problem which can be resolved through a biological intervention, which is medication, or a psychological intervention, which is counseling? Something for you to think about. The other question is, who is missing from the research which is informing all of the things that we are doing here? A substantial proportion of research within the mental health space happens in the global north. And we adopt it most of the times unquestioningly. Research on what is a mental health problem? How do you diagnose a mental health problem? What are the features of depression? Research on what should be the response to it in terms of the treatments. All of that research, or most of that research, is coming from the global north. And we have to change that moving forward. It needs to be changed in terms of the evidence that is generated. It needs to be happening in the global south. It needs to be happening in Asia. It needs to be happening in Africa. It needs to be happening in South America. We need to be mindful of the cultural context within some of these interventions are delivered. So even if we adopt something from the global north based on evidence, it needs to be adapted for the context for it to be relevant to the people you're delivering it to. And finally, we also have to be mindful and respectful of indigenous knowledge or traditional knowledge, but not blindly so and romanticizing it. We need to be testing it. And if it works, we need to be using these traditional methods, this indigenous knowledge, much more if we are able to generate evidence on it, because these are contextually and culturally embedded and are going to be more acceptable to the populations we deliver it to. And the third question is, are we training young people, some of you are probably learning psychology here, for scarcity or transformation? Because if we use the metric of the treatment gap, which I spoke about earlier, which is a large proportion of people with mental health problems do not have access to mental health services, then the simple answer is train more people. You're responding to the scarcity. You say people don't have access to mental health care because we don't have enough psychiatrists and psychologists. The simple response is train more people. But the issue, as I've articulated it, is not simply the treatment gap. And so we need much more of other professions. We need more of policy translation. We need more of advocacy. We need more of systems redesigners. We need a lot more of, if we are thinking about technological innovation, then people who are doing digital governance and digital ethics. So it's not just about training more psychologists and psychologists moving forwards, but there are going to be roles for various different stakeholders to take part in the revamping of the mental health system. And let's think a little bit more of conceptual innovation as well, right? So it's not just about technological innovation or systems innovation. We also need to rethink how we think about some of these things, how we design these concepts, and because these concepts inform how we design systems. So we need to think about diagnosis versus distress and social determinants. And I don't need to kind of elaborate more on this, just for you to think about that farmer that I spoke about, where there was a tension between a diagnosis of depression and the social determinants of poverty and how that causes distress. I think that's a living example of how we need to conceptually rethink how we think about mental health. I can't really see what's up there, so I'm going to, okay, it's clinic versus the community. So again, as I said, our systems are designed to provide care to people within hospitals and clinics, which are largely inaccessible to most of the population because of geographical or financial problems or barriers. And hence, we need to be able to design systems which provide people mental health care close to where they live. Okay, I'll need to move a little bit now. Yes, we need to be, do we situate mental health problems within individuals as we did with the farmer from Vidarbha and say, or let's take a more a potent example of a woman who is experiencing domestic violence and then resulting in depression. Do we situate the problem in the woman with depression? Or do we situate the problem in the structures and the systems around her? Do we situate it within patriarchy? Do we situate it within norms or gender norms? Do we situate it within the domestic violence that she is experiencing? All things for you to think about. So the final piece on episodic treatment versus lifelong treatment. And as I said, the way healthcare or mental health care is designed at the moment, it's designed to respond to people when they have an acute illness. When in reality, mental health is something that all of us should be aspiring for all the time. So prevention, promotion, treatment, and rehabilitation and recovery. So we have to be thinking at the other two sides of mental health as well. Let's look at inclusion and how we would want it to be. Moving forwards, we need to be thinking about socio-economic inclusion, which basically means that if I have a mental health problem, I don't have to spend huge amounts of money which can lead to poverty because of catastrophic expenditures, which is quite common in a country such as India, for me to get mental health care. If I have mental health problems, I need to get an intervention which aligns with my culture and context. We need to think about geographic inclusion, which means that if I have a mental health problem, I need to get services close to where I live. And if there are no services close to where I live, then technology comes into the picture, and we think about things such as telepsychiatry or telemental health. We need to think about lived experience inclusion of what about people with mental health problems and how do we integrate them into the systems that we design. So the contribution of people with lived experience in designing mental health care, the contributions of people with lived experience in governing mental health care, and the contribution of people with lived experience in delivering mental health care as peers as we move forward. We need to be thinking about workforce inclusion. We need to be designing our mental health system which is not dependent on specialists, but in which there is a role for non-specialists. We need to create career pathways which are clear for non-specialists, and we need to acknowledge the work and celebrate the work of non-specialists in the existing health systems. And finally, epistemic inclusion, as I spoke about earlier, ensuring that there is decolonization of knowledge that is generated, which informs the systems that we develop, and ensuring that the knowledge that is generated in the global south informs the health systems that we put in place.